So I have a case here. It's a 40-year-old man who presents with shortness of breath. So he actually presents to ER following abnormal outpatient TTE results. So over the past couple weeks, he has been complaining worsening fatigue and shortness of breath. And he also noted that he has weight gain, and he kind of short of breath when he exerted himself over the past 2 months. Abdominal fullness, decreased oral intake, deny any other symptoms. So just to backtrack to to the time where he first became unwell, he was really perfectly well until like February 2020. He complained of sore throat, was having fever and chills. He went to urgent care and was diagnosed with strep pharyngitis, and he got a week course of amoxicillin. And then in May to June, he was noted that he was having shortness of breath, fatigue, and again he went to urgent care. They ordered X-ray at that time, and he was told that he has fluid in his lungs. Somehow they prescribed him 10 days of doxycycline, presumably for pneumonia, and then he noted that his symptom never improved. So he went to his PCP. His PCP actually prescribed him LASIK and referred him to cardiology. He was ordered a transthoracic echo as well at that time. In regards to his past medical history, chronic bronchitis, surgical history, mastoidectomy 20 years ago. Home medication wise, he only take this as needed. No known drug allergies. Family history, pancreatic cancer and type 2 diabetes. Otherwise, no known family history of heart failure. He works in construction, ex-smoker, smoked about 18 pack years, but quit 3 years ago. He drink quite a significant amount of alcohol, actually, about 10 to 15 cans of beer at least once a week. Remote use of cocaine. In regards to his physical examination, he's fairly obese gentleman. When I saw him, he wasn't in like acute distress. He looked very comfortable laying on his bed. The only significant exam at that time was actually elevated JV. That he has JVD measured about 10 cm. There's also a right cervical lymph node that's firm, mobile, and non-tender. Small distension of his abdomen, otherwise pretty unremarkable findings. Bilateral trace pedal as well.
Looks like a sinus rhythm, probably a little faster than 100, and axis looks okay, just a little leftward, but this looks okay. Overall, there's a poor RA progression in precordial lead, but obese patient, and the RA preserved in V6. So tendency to have a low voltage in the ring lead. Otherwise, looks okay. Poor RA progressions, maybe some left atrial abnormalities.
In regards to his labs, pretty unremarkable BMP here, CBC as well. His NT-proBNP is in the range is 2,000 plus, slightly elevated ALT here. Otherwise, COVID test, PCR is negative, and HIV test is negative.
Let's just pause for 1 second to talk about the NT-proBNP. So just to summarize, this is a 40-year-old gentleman who has a history of bronchitis and, not too much else, an old mastoidectomy. Not related to this. But at any rate, he this winter had some cold, a strep pharyngitis. He put on antibiotics, came back with seems like another cold or shortness of breath. Went to urgent care. They gave him antibiotics again, and a chest X-ray looked wet, but they still gave him antibiotics. They went to his family doctor, and family doctor put him on a small dose of Lasix, 20 milligrams once a day, but was wise enough to get an echocardiogram, which we'll talk about in a minute. But these are his labs, which, on the surface, not terribly remarkable, except the ALT is high at 91. Now we know he drinks a lot of beer and whatnot, but that seems out of proportion. And the N-terminal pro-BNP is 2878. So usually Dr. Ginsburg talks about the pro-BNP. But one of the things, so this is clearly elevated. I don't think anybody would think it's not elevated. But what you may not realize is that pro-BNP, it kind of works inverse to obesity. So the bigger you are, the larger you are, you can have heart failure with a lower BNP value than a normal sized person. So this 2878 is high, and it's even higher if you adjust for the fact that his BMI is 45. So this is a gigantic human being over 300 pounds. That pro-BNP is strikingly abnormal in a person. And we'll have to explain the liver function abnormality as well, whether that's related to alcohol or something else.
This is the X-ray.
Yep.
Yeah, it's definitely PL lateral view is definitely cardiomegaly. So when you look at the most probably the left ventricle is dilated, and when you look at the lateral view, you have some fullness of the right ventricle part of it, as well as LV is dilated. So probably the LV is could be mildly dilated. Also, we have pulmonary venous hypertension. So after then, once you have both ventricles dilated, most probably we're dealing with the left atrial dilatation also. So probably both ventricle dilatation, left atrial dilatation, and pulmonary venous hypertension.
Yes, there's a lot of findings on here. Just going to see if we can point to some of them because it's worth it for the first year fellows. Excuse me, Jay. I'll just slide over. Not just because I can't see. But, the carina is lifted up a little bit here, suggesting the left atrium in here is enlarged. You see that. The left cardiac solid is huge, goes way out here, much further laterally than you'd expect. The pulmonary vessels, arteries are enlarged here. You can see it a little bit here. And on the lateral view, there's filling in a little bit of the retrosternal space over here. So that suggests that the right ventricle is enlarged here. The left ventricle is enlarged here. The left atrium is big. I think some of the major findings. Now, the lung bases are clear. There's no pleural effusion seen. But definitely a big heart with evidence of left atrial and right ventricular enlargement as well. Okay. The next is the echo, which we were told at the beginning it was sent to us because of the echo.
The left is for the new fellows, it's the peristernal long axis. So you see to the right there, in the bottom right, you see the left atrium. That looks markedly dilated on this view. Again, that's 2D view. And then looking at the mitral valve, the mitral leaflets, the mobility of them look rather decreased and somewhat apically displaced. They're not fully coming back to the closure. And as far as the LV function, in this view, you're looking at the anteroseptal wall at the top and the infralateral at the bottom. Both walls look reduced, so this is probably going to be a globally reduced function. And finally, at the very top, you see a little bit of the RV, the more anterior structure, that also looks reduced. So left atrial enlargement. To the right is the short axis. This is the short axis of the mitral valve. You're looking at the left ventricle. You're looking at the mitral valve level. Can't really tell much from this view. You may have a little trivial pericardial effusion below there. So from these two views so far, you got a dilated left atrium and probably at least moderate severe LV dysfunction, probably severe, but we need more views. So the right here, you can see the E-point septal separation there on the left through this is an M mode through the mitral valve, greater than 1 centimeter at least. And then on the right, you're looking at the LV, the two-dimension values here. So typically, an LV end diastolic diameter, normal would be a little under 5. It varies for men and women, but under 5.8. This is 7.0, so that's a pretty markedly dilated LV, and the measurements look pretty good. That posterior wall thickness of 1.5, that's overestimated. That to me looks like an error. She's in the pericardium, I believe. So this is a markedly dilated left ventricle with probably normal wall thickness. And if you were to measure that left atrium, that's probably at least 4.5, 5 centimeters by 2D, which is also pretty dilated. So dilated LV by the M mode. So this is an apical 4-chamber, although you're not bringing in the right-sided structures very well. To the right is the left ventricle and the left ventricle and the left atrium. To the left should be the right ventricle and right atrium, which you're not seeing that well. This is not a good. Is there any better images of the apicals? I think you have an apical 2 on the right. So here's a subcostal he's gone to now. So the right for the new fellows, the right ventricle is on the top. Left ventricle is more towards the bottom there, and you have your 2 atrium as well, right atrium above the left atrium. And you see also there's an effusion there, mostly anterior adjacent to the right atrium. There's a moderate effusion there. It doesn't seem to extend in kind of distally to the RV apex or whatever, but he does have an effusion there that's looks like it's causing some RA collapse, but you don't use that to diagnose tamponade. And they're checking the tricuspid inflow velocities. Kind of poor spectral Doppler. I don't see. It's hard to tell there if there's any significant variation. Maybe a little bit, but not. I don't think it reached significance. And I can't even see that. I mean, I guess you see the tricuspid valve, but you really can't see the right-sided structures there at all.
What's interesting is how tachycardic he appears to be, which is
Right.
going along with his very poor LV function. He's dependent on that heart rate to generate cardiac output because he has no squeeze. So he's tachycardic for that reason.
Right. And I suggest there's probably biatrial enlargement. I can't see the right atrium, but looking kind of, it looks almost as big as the LA in some views. Probably it's biatrial enlargement as well. So this is much better now. So this is with Definity. Again, the same 2 images we saw before: peristernal long axis on the left and short axis on the right. Here you can appreciate really how dilated the LV is and hypokinetic on the left. So EF is less than 20%, and that's really what you appreciate here is the degree of LV dilatation. The right here, we've gone to an apical 4, it looks like, on the left, and an apical 2 on the right. Again, marked LV dysfunction. There's some swelling of echo contrast in the LV apex. It's consistent with the low flow state, but I don't see any formed thrombus on these views, at least.
So the summary of these echo findings basically are showing severely dilated LV, LVS less than 20. There's apical displacement of the mitral leaflet coaptation point. The read was actually RV size is kind of normal, systolic function is normal as well, but there's no evidence of tamponade physiology, though there's a moderate anterior pericardial effusion there on subcostal view. He was given furosemide 40 milligram IV twice a day over the next 2 to 3 days. He had great response to the IV Lasix, and his body weight decreased from like 314 pounds to 302 pounds. And his blood pressure is relatively kind of stable. We started him on some medication for his new onset heart failure, Corac, Valsartan. His heart rate come down nicely to 86 beats per minute, kind of like in day 2 or 3. So he underwent coronary angiogram day 2, I believe.
Yeah, so this looks like a widely patent coronary tree. It's fairly characteristic of what you see when there's a big dilated ventricle. This would be a non-ischemic cardiomyopathic picture with big coronaries. You can see the wall motion here. You don't see any coronary disease as such. There's an area for the new fellows. This is an RAO caudal view, and the characteristic of that, you see the left main on the left. The circumflex comes straight down, and the LAD goes straight out, and horizontally on the right. Wraps around the apex. Big, beautiful vessels, the way you would probably like your coronaries to look, minus the LV. There's a big gap in the center of the major vessels, the LAD and the circ. And so you always want to keep in mind, should there be another marginal vessel there? Is there something missing? But I doubt it. I think this is just a very big, very good-looking circumflex system. I don't know from this one view if it was done from the wrist or from the groin, but for those who are interested in the cath aspect, this is one where it's very typical of aortic stenosis and with dilated cardiomyopathy, you need more flow in order to visualize the vessels. A good technique is to use a coronary guide catheter instead of diagnostic catheter unified French guide, you'll see the vessels much better. But basically normal from what I see. And this is the aleocaudal view. It's the so-called spider view. Circumflex comes down diagonally toward the bottom right. The LAD goes up and over. It's kind of a hybrid, more like an AP caudal, I suspect. But again, no disease that I can see. Maybe a little diffuse disease in the mid-LAD, but nothing significant. And here you have your right coronary, again, kind of a little underfilled. Pretty good circulation, either balanced or right dominant. Can't see the small vessels well enough. Basically normal.
Okay.
So so basically, it's unremarkable, and LVDP is 35. So we actually ordered MR of the heart as well, just to find out if he has any underlying infiltrative causes of the non-ischemic cardiomyopathy. So I can just provide the summary of the CMR. So it was read as dilated cardiomyopathy. EF was less than EF was actually 10%. That's small pericardial effusion, mitral regurgitation. There was also mentioning of delayed myocardial enhancement in segment 2 and 3, mid-wall striae, and some other common findings of RV strain. I can show you here. This is probably that mid-wall striae, but yeah, as you can see here, this is the short axis view, but I'm not sure the significance of it.
So JL, I think segments 2 and 3 are septal segments, if I remember correctly,
Septal.
but not lateral wall. I think it's anterior. I think it's sort of near the base or the mid portion of the anterior septal, inferior septal, which I actually don't see in this image. I mean, I don't see any LGE in that image, but for what it's worth.
When you look at the short axis, this one is not typically they pick up the right frame, but when you look at the RB insert to the septum, upper septum and lower septum area, sometimes you can see that little enhancement if patient has RB dilatation or RB strain. So it's quite common findings for that. Also, same thing you can find with the patient with the HOCM, but that's what I tried to describe it. But this image is not clear; does not show that frame.
So what was the overall conclusion of the MRI? Is this consistent with anything special about carditis or just idiopathic dilated carditis?
Basically idiopathic.
Okay.
Yeah, it's not consistent with any other common
Okay.
pathology.
Okay.
So, just I think it's day 3 or day 4 prior to discharge. He's subjective to feeling better. So we set up a patient appointment for him to be followed up. His home medication basically was a low dose Carvedal 6.25 twice a day, furosemide oral, and he was put on Entresto as well prior to being discharged.
Yeah, so let me ask Dr. Halleck then. Well, so patients coming in, it's a new diagnosis of dilated cardiomyopathy. We've done the workup, not coronary disease, so it's not ischemic. How do you decide what medicines and in what order, and how often are you using sacubitril valsartan as an inpatient?
I mean, you want to send patients home on, beta blockers and an ACE or an ARB potentially, but an ARNI is definitely, according to the guidelines, a better option than an ARB or an ACE. So it's definitely good to start that up as well as an inpatient. We have some studies that support that.
Okay, good. So they already started, and then the plan would be, of course, to potentially titrate that upward as an outpatient, correct?
Yeah, I mean, when the studies were done on these drugs, they were done with higher doses, not the lower doses. So the benefit was really with the higher doses, but you got to start with the lower doses and try to titrate up. You really want to try to ramp them up as much as tolerated by the patient. And all the other parameters like heart rate and blood pressure and renal function, look at that as well. But again, the benefit was seen in higher doses, so you really want to try to increase them.
Right. And we're going to have a talk on this in a minute from Dr. Mazzarelli, but let me just ask you guys, what about an aldosterone antagonist such as spironolactone?
It's not a bad idea. Definitely, you could add that on. Sometimes with patients with a new diagnosis, they start a lot of medications, they start feeling side effects, and they may, stop all their medicines. You kind of want to start things slowly, in my opinion, and then add things on as time goes on. But it's definitely according to the guidelines, that would be beneficial.
Right. So eventually that's something to consider. And you're
Definitely part
right,
of the
polypharmacy is tough for these patients. They come in on nothing and they go out on 4 or 5 or 6 medicines. So, but you have to keep that in mind because there's evidence based behind it.
It could be overwhelming for the patients at first. So I think you try to do things gradually, and then you definitely want to get them on an aldosterone antagonist. That would definitely be beneficial too.